بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. It is my pleasure to welcome you all in our 11th Research Day. Annual Research Day is a cornerstone calendar event in our university, and hopefully it will continue yearly. Today, Riyadh Ilm University, with the collaboration of the Saudi division of the IADR, will start the virtual Research Day. نرحب بكم جميعا في هذا اليوم العلمي، وانطلاقا من أهمية البحث العلمي للمجتمع بأكمله، نبدأ نشاط اليوم العلمي الحادي عشر لجامعة رياض العلم بالتعاون مع القسم السعودي للمنظمة العالمية لأبحاث طب الأسنان، وبسم الله نبدأ.
ألم تر أن الله أنزل من السماء ماء فأخرجنا به ثمرات مختلفا ألوانها ومن الجبال جدد بيض وحمر مختلف ألوانها وغرابيب سود ومن الناس والدواب والأنعام مختلف ألوانه كذلك إنما يخشى الله من عباده العلماء إن الله عزيز غفور.
الحمد لله رب العالمين، والصلاة والسلام على رسوله الأمين سيدنا محمد وعلى آله وصحبه أجمعين. ضيوفنا الأعزاء، سعادة الأخ الدكتور عبد العزيز عبد الباقي، وكيل وزارة الصحة المساعد للتخطيط والتمييز المؤسسي، سعادة الدكتور كريستوفر فوكس الرئيس التنفيذي للجمعية العالمية لبحوث طب الأسنان في أمريكا. Welcome Dr. Christopher Fox, the CEO of IADR International Association of Dental Research. إخواني وأخواتي الكرام، منسوبي الجامعة إدارة وأعضاء هيئة تدريس، أبنائي وبنات الطلبة، علماء المستقبل بإذن الله، حفلنا الكريم، السلام عليكم ورحمة الله وبركاته. أهلا ومرحبا بكم جميعا، وأشكر لكم المشاركة عن بعد في هذا اللقاء البحث السنوي الذي اعتادت على تنظيمه جامعة رياض العلم كأحد واجباتها لدعم حركة البحث العلمي بالمملكة، وحيث أننا في هذه الجامعة نركز على تدريب وتعليم طلابنا مهارات البحث العلمي، فإني أجزم أن المهارة الأولى والتي يجب على كل باحث اكتسابها وتنميتها باستمرار هي القدرة على بذل الجهد المتواصل لإنجاز البحث العلمي مهما كانت الظروف المحيطة، بمعنى أن تستمر قدرتك لإنجاز بحثك وتقوم كل يوم بالسعي لإكماله وإنجازه مقاوما للعديد من التحديات، ولأنك على مدى الأيام سيتحول جهدك البحثي المستمر ليصنع منك عالم المستقبل، وستجني ثمراته في عملك وحياتك، وبذلك تخدم وطنك والبشرية عامة. أحب الأعمال إلى الله تعالى أدومها وأقل، حديث صحيح. لقد حرصت جامعة رياض العلم مبكرا منذ تأسيسها على تشجيع البحث العلمي كجزء من رسالتها، وأنشأت وكالة الجامعة وعمادة ومركزا لخدمة البحث العلمي، وعقدت عشرات المؤتمرات والندوات العلمية المحلية والدولية في رحابها، كما ساهمت في نشر بحوثها في الدوريات العلمية والمؤتمرات داخل وخارج المملكة، وأكملت العام الثامن باستمرار إصدار مجلة علمية محكمة لعلوم وصحة الفم، وهي المجلة السعودية لعلوم الفم، سعودي جورنال فور هيلث ساينس. كما قدمت الجامعة دعما إداريا وماليا لعدد من الجمعيات العلمية والمهنية، ويأتي على رأسها الفرع السعودي للجمعية الدولية لبحوث الأسنان، والذي نسعد للعام الحادي عشر بمشاركته في يوم البحث السنوي. ختاما أقدم أسمى عبارات الشكر والتقدير والعرفان لمقام خادم الحرمين الشريفين الملك سلمان بن عبد العزيز آل سعود، ولصاحب السمو الملكي الأمير محمد بن سلمان آل سعود ولي العهد الأمين رعاهم الله على الدعم والتشجيع والرعاية الكريمة الذي تجده الجامعة ومنسوبيها منهم. والشكر موصول لمعالي وزير التعليم الدكتور حمد بن محمد آل الشيخ وزملائه العاملين بالوزارة على الدعم والتسهيلات، وأخص بشكري وتقديري لجميع المتحدثين الرئيسيين والباحثين الذين شاركونا اليوم بثمرة نتاجهم البحثي. والشكر لجميع زملائي في جامعة رياض العلم والمشرفين على البحوث على الجهد والعمل البحث النافع الذي ساهموا به. حفلنا الكريم. I like just to extend my sincere thanks for our guest, Dr. Mr. Abdulaziz Abdelbagi and Dr. Christopher Fox from the United States, where we have the honor, to join us virtual from the state. And I like to extend my sincere thanks for all our students and colleagues at REU for their excellent work to do the annual research day every year. This is the 11th one. It is the new experience for us, to have it this year as a federal one. I like to welcome all of you, and in the same time, the best thing, I like to show you the work of one of our students where he tried to present to you a video about this activity. Thank you very much. Hope to enjoy this research day.
إن التعليم وسيلة أساسية تحقق بها التوفيق الرعاية أمتنا الإسلامية نحو التقدم والازدهار والتنمية والرقي الحضاري المعارف والعلوم النافعة.
مثل الفرق بين هذا الهاتف وبين هذا الهاتف، هذا ما سوف نعمله.
طموح وحلم جامعة رياض العلم للمستقبل أن تخدم الوطن وخارجه بعلم نافع يصنع مستقبلا باهر، وبحث مفيد يحسن حياة الناس، واختراع يخدم البشرية، وبرامج تعليم مستمر مدى الحياة.
A dental intern at Riyadh University, the global burden of disease estimated that oral disease affected half of the world's population, with tooth decay and permanent teeth being the most prevalent.
Oral microgyne class 2 considered the most frequent condition in orthodontic practice.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. It gives me a great pleasure and joy to be here and to witness today the fruits of months and years of research work being cultivated today in this outstanding day. I'd like to start by welcoming our esteemed guest, Mr. Abdulaziz Abdelbaghi, the Assistant Deputy Minister for Planning and Organizational Excellence at the Ministry of Health, Saudi Arabia, Dr. Christopher Fox, the Chief Executive Officer of the International Association for Dental Research, our respected Chairman of the Board of Trustees, Rector, Vice Rector, Deans, Vice Deans, and faculty members. And last but not least, the stars of the day, our young researchers, the postgraduate and undergraduate students and interns. I'd like to speak about the achievements that we had during the last academic year for the Research Center. We had an increased number of published articles in international journals, an increased number of proposals registered in the Research Center. Moreover, we had launched the new Research Center portal, which actually automates and makes all the registration process for researchers fully automatic and automated. We have also are running today the 3rd annual Summer Research School, which we have over 150 participants. We are proud to have increased and continuous external collaborations with different research institutes. We are also proud to have the 8th volume of our scientific journal, the Scientific Journal.
So now we will move to our first keynote speaker, Dr. Fox, the CEO of the IDR. He will give us a welcome speech. So Dr. Fox, the mic is yours now.
Thank you. Dear Dr. Asri, Professor Al-Shamari, Dr. Al-Khadi, Mr. Abdelbaghi, IDR Saudi Arabian Division President Al-Shamari, Vice President Al-Safa, Secretary Bagish, Treasurer Al-Tobayt, distinguished guests, IDR members, and IDR student members, I'm delighted and honored to be with you at this virtual opening of the 11th Riyadh Al University Annual Research Day in collaboration with the IDR Saudi Division. I bring greetings from the IDR Global President, Professor Pamela Denbeston from the University of California, the entire IDR Board of Directors, and the Global Headquarters staff. IDR is very pleased to see the growth of dental, oral, and craniofacial research in Saudi Arabia. I was impressed with the quality of the science presented at the IDR Saudi Arabian first virtual poster presentation last month that I had the pleasure of attending. At the 2018 IDR General Session in London, the IDR Saudi Arabian Division was recognized as one of 3 divisions with the highest % growth in membership. While 2019 saw membership dip when our meeting was in Canada, I was pleased to hear from our membership department that 2020 membership has increased again, despite the canceled general session due to COVID-19. To put our current situation in historical context, in the midst and the immediate aftermath of the influenza pandemic of 1918 to 1919, William J. Guise, a professor of biochemistry at Columbia University in New York City, founded the Journal of Dental Research and the International Association for Dental Research. An estimated 1/3 of the world's population was infected with what we now know as an H1N1 virus. The pandemic killed 50 to 100 million people. Professor Guise could not have missed the pandemic, nor the public health messages that would have blanketed New York City at the time, yet it was in this environment that IDR was founded. Now, 100 years later, the world is suffering from another global pandemic, COVID-19, caused by SARS-CoV-2 or the novel coronavirus. In a year where IDR planned to celebrate our centennial of the IDR General Session in Washington, D.C., we find ourselves in the aftermath of a canceled meeting and many of us working from home as countries implement some of the very same public health measures from 1918 to 1919. However, IDR will rise to this challenge and we will continue our mission of driving dental, oral, and craniofacial research for health and well-being worldwide. So what has IADR done in response to the pandemic? One, the governance of the association continued unabated, and IADR held its first ever all virtual IADR council meeting in March. Two, IADR established a COVID-19 resource page on our website to share research articles, association news, and guidances issued by international and national authorities. Our journal, the Journal of Dental Research, and the JDR Clinical and Translational Research are fast-tracking any reviews of any COVID-19 manuscripts, and any of those that are accepted will be free of any access controls for the world to read. By the end of June, IADR will launch a new IADR community that will encourage online conversation and collaboration with our membership year-round. So stay tuned for that announcement in the coming weeks. IADR has also rearranged our 2021 and 2022 general sessions. The 2021 meeting will now be in Boston in July 21st through the 24th, and the 2022 meeting will be in Chengdu, China, June 22nd through the 25th. Further, IADR is planning for hybrid meetings in the future, allowing for both in-person and virtual opportunities to both present and participate in our meetings. And this brings me to my one and only slide, which I would like to share with you. For next year's Boston meeting, the deadline for symposia will be November 16th, and the abstract deadline will be March 1st. I hope to see many of you in Boston next year, either in person or participating virtually. In the meantime, keep up your research and help us drive dental, oral, and craniofacial research for health and well-being worldwide. Thank you.
Thank you, Dr. Fox. We are glad to have you with us today. So now we will move our second keynote speaker, أستاذ عبد العزيز عبد الباقي، الوكيل المساعد للتخطيط والتمييز المؤسسي في وزارة الصحة. تفضل أستاذ عبد العزيز.
Thank you very much. السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Thank you, Professor Abdullah, for inviting me and for the fruitful collaborations with the Ministry of Health and Riyadh Al-Alm University and for your leadership team. Dr. Christopher, it's a pleasure to meet you here with this conference. And dear guests and participants, I'm happy to be with you today, sharing with you very few slides about preparing the future for excellence and how to be open and ready for future time in health, especially in healthcare. So if you think of healthcare, about the generations, in one organization, in a hospital or in a clinic or in a university, how many generations do we have around us? For us as leaders or for supervisors or faculty staff, we're dealing with different ages, group of ages of population, of staff, students, and trainee, how to treat them and how to consider their needs around us, and how to make sure that we are preparing the environment for them to excel, to innovate, and to make them productive to do more research and more development in their organizations. So considering the generations who established the infrastructure, the people who served the countries and the organizations and the fields in the last years, and the future generations who will be doing the job and who will be facing very difficult challenges and very difficult environments in their day-to-day work. So if we think of the many organizations, of course, are speaking about generations and how leaders prepare the environment for the future instead of taking care of the current challenges and the current projects or current researches or teaching or productivity or serving patients in the current status. So staff that we work with, considering their needs, creating the open environment. For example, the people who with the new generations, the fresh graduates, when they be prepared for the future work, how leaders become ready for them, because the gap in the generation will create, sometimes it creates challenges for people to be accommodated and to see their future and to create their career path and to be more productive and more effective in their environment. So starting from awareness about the generation gap will give very good idea and very good understanding about that gap and how to manage this gap and how to create more opportunities for them to innovate and to find themselves in their career. For example, the new staff or the new people who join the work environment nowadays, they look more in what's the value of doing this, what's the vision, what's the mission of this organization, and what kind of value I'm going to add off to it. Instead of in the past, like people want to be part of an environment where their bosses will give them the direction, what to do, and they'll be only following procedures and processes, and they'll be doing it. This existing current generations, they want to understand more, and they want to really go in depth about the value that they're adding to their work, and to connect this to their personal mission and to the country mission and to the organization mission. We're facing this a lot. For example, when we interview staff for recruitment, many of them are interviewing us instead of us interviewing them. So they ask more questions. So they want to understand the purpose, the value, and the mission and vision of the organization, so they become an effective part of it. Of course, with the transformations that's existing now in many countries and many organizations, the fourth industrial generation is coming, and it's very different than the way business is designed in the past. When I say business or industries, it's not only industries and manufacturing. Healthcare is an industry. In healthcare, you have all kinds of industries where you have medical, engineering, administrative, you have housing, and you have all kinds of services in one organization. You have food services, you have infrastructure. So many industries are working in healthcare. How to put them together and how to connect all the dots together, serving one goal and one mission, is the current challenge that we're working with. The silo business or the vertical business that many of organizations are conducting, this organization will not survive in the future, and they will find very big challenge for them to survive and to continue. So opening ourselves and breaking the silos between departments, between organizations, and between many industries, this is the environment that will create innovation, it will create better environment for research infrastructure, and it will give us what we're looking for Vision 2030, thriving economy, ambitious nation, and so forth. If we think about the excellence model, so excellence is not something that we cannot measure and we cannot work with. In every environment, in every business, you have data collection, you have data that's produced by your business, in your dental practice, in your medical practice, surgical, even in HR, in food service, in engineering, in transportation. So what kind of data we're producing? How do we capitalize on this data? And how do we make it open for other industries so they can benefit from it? And how to make it open, connected, integrated, so we can understand and produce more efficient systems. I'll give you an example. In Ministry of Health, for example, the way we deal with the private sector, usually the branches of the ministry sends inspectors to check the practices, the compliance, the standards. But if we create a unified system with unified definitions, with unified database, we can communicate with more openness, with more transparency, serving our purposes, and we can understand our shortcomings and what kind of compliance standards we need to understand so we can improve and develop our system. Especially the management part, because sometimes management is separated than the clinical practice. How to close this gap and how to consider people who provide services to patients and to the public are our customers. How to define customers and how to make sure that we understand who our customers are. I'll give you an example. The direct customers for doctors, dentists, surgeons are patients themselves. But for the administrators, for the management, their direct customers are the care providers. These doctors are customers to the management. For people who work in regulatory parts or in the ministries, for example, their customers are the organizations that provide services to their customers. So there is a chain of customer value that need to be considered. Ultimately, patients are the final customer, but all of these needs need to be cascaded, need to be aligned, starting from the regulatory affairs all the way where services are rendered and provided. So opening the organization, breaking the silo, connectedness between functions will create better environment for excellence, leadership, and better platform for research excellence as well, because many colleagues who are conducting research are facing big challenges in data collection, accessing information, the prioritization for what kind of topics we need to work with. We're facing many challenges with this, but focusing on the infrastructure, what are the enablers, catalysts for this infrastructure need to be considered in place, and our country is playing a big role in building the infrastructure for excellence for the fourth industrial generation. So I'm not talking about technology here, I'm talking about the technology that enables, improve the culture, psychological safety, openness, collaboration, competency, and leadership that drives all of these factors toward excellency. And the role of leaders in giving purpose to their staff, their students, to their colleagues, by providing security and letting them trial and error, testing and challenging the existing processes, and offering nourishment to their career path, creating relief when they do mistakes, and how can we create better environment for them to excel, and giving them control instead of centralizing the authorities. Also empowering their growth and championing education not only between the walls of the universities, also education within the healthcare facilities themselves. And how do we encourage and making sure that culture in our organizations are aligned with our values, our set of behaviors, and how can we create environments that enable them to do what they're looking for. So our challenges with the leadership always is the future generations and how to make sure that we are enabling them, creating better environments for them. Thinking of the existing management frameworks of organization, chart, policies, procedures, can we challenge that by creating more networks that not necessarily depending on the organization chart, and how can we make better environments for people to work with other departments, with other colleagues, regardless of where they are, regardless of which department they belong to? How can we break these walls that prevent people to innovate and to think outside the box? Many times we tell our staff to think outside the box, but we are creating these boxes for them, while it's our job to break it and create more networks of innovation, networks of research beyond our walls and beyond our workplace. Nowadays, with the COVID-19 fights in Saudi Arabia, about thinking outside the world, what other worlds are doing in terms of dental, infection control, the pandemic itself, how do we benchmark and where do we position ourselves with other countries to understand the shortcomings and how to improve that? Alhamdulillah Rabbil Alameen, Saudi Arabia is ranked from tier 1 countries that are classified or categorized as tier 1 in COVID fight. 3 of the countries are from the Gulf region. Saudi Arabia is ranked number 17. And nowadays we're working on understanding these shortcomings and how do we work with other parts in the Gulf, in the governmental entities, where are the areas that we can improve and where are the areas that can be improved in our fight against COVID-19. So these are just examples, 3 slides of examples on openness, sharing information, breaking the walls between governmental entities, governmental organizations, and other countries working together, fighting the same, for the same purpose. And hopefully in the next month, we will have better results and better score. And many of us as researchers and healthcare colleagues, we have the knowledge, but the gap is in doing. So the greatest gap in life is one between knowing and doing, and how to minimize that gap and how to make it shorter is our challenge time after time. And all of this activities by Riyadh al-Ilm, by other universities, by the Ministry of Health, by many other organizations in Saudi Arabia are very much aligned with Vision 2030, as mentioned in the video. Nowadays will be very different than what will be happening in the future. What is our role as leaders, as colleagues who work now in healthcare field to prepare the future for the future generations? So I would like to thank everybody in this conference for inviting me and for being with you. I will enjoy my time watching and learning from your presentations. Thank you, everyone. I will end my presentation here. All the best.
Thank you, Mr. Abdulaziz. We are glad to see this level of excellence in our ministry. Thank you for your speech. So now we will move now to our researcher. We had 82 total of abstract we received, and we had around one 2 days ago, and now we have 18 nominated research. So we will start first with Dr. Ali Barakat. So Dr. Ali Barakat, could you start now your presentation?
Bismillah ar-Rahman ar-Rahim. On behalf of all my colleagues, I would like to welcome the guest speakers of Riyadh Al-Ilm University. I am glad to present my e-poster today for under the title of Fracture Resistance of Different Veneering Techniques of Lithium Disilicated Crowns with the direct supervision of respected Professor Mohammed Al-Umari. So, according to Federico et al. 2012, the all ceramic restorations are in high demand due to the high aesthetic demands of patients. However, the clinical failures of those type of clinical restorations are the major drawbacks. Unfortunately, the literature has lack of evidence which type of veneering techniques would provide the best fracture resistance for those type of lithium disilicate crowns. The aim of our study was to evaluate the effect of 3 different veneering techniques on the fracture resistance of lithium disilicate crowns. Moving to the materials and method, the total sample size comprises of 30 crowns subdivided into 3 subgroups. Each group contains 10 crowns of different veneering technique. So starting the steps, the classic full ceramic crown preparation was started, followed by final impression. Step number 3, in which 30 identical epoxy resin CAD/CAM testing dies was fabricated utilizing the CAD/CAM technology. Then the products, the 3 groups of lithium disilicated crowns were color-coded, and the cementation process was done under uniform, constant pressure, and lightly cured in specific angulation according to the manufacturer instruction, followed by the thermocycles that were done for the total sample, and finally the fracture resistance test was performed for all the samples. The results of our study showed clearly that the CAD/CAM group provided the greatest value of fracture resistance, followed by the layering group, and the least fracture resistance values were recorded for the group of pressed veneering technique. So the statistical analysis showed clearly the significant result where the p-value was less than 0.05, and we concluded from that the CAD/CAM veneering monolithic lithium disilicated crowns demonstrated superior fracture resistance values as compared to the other groups. Our recommendations for our colleagues for future studies: better to utilize the natural abutment teeth, and better also to increase the sample size, as well as better to increase the number of thermocycles, and also better to use the mechanical chewing simulators. Kindly feel free to scan the barcodes below for the references, as well as please feel free to contact me for any further details. I would like to thank my university for organizing this great scientific event during this exceptional circumstances. Thank you so much.
Thank you, Dr. Ali. So now to move our respected judges, Dr. May Al-Khdairi and Dr. Afro Rashid.
Assalamu alaikum. Thank you so much, Dr. Ali Barakat, for this lovely research that was conducted in the lab. I really like it, and your recommendations for having a larger sample is completely valid. I just wanted to ask you, out of curiosity, were there any extraneous variables that future researchers would take into consideration that might affect the results of your study? Thank you.
Thank you so much, Dean Dr. May, for your question. Actually, yes, one of the variables that should be considered better also to utilize the natural abutment teeth to reflect more realistic results, and also to have more reliable recommendations. Thank you.
Assalamu alaikum. Dr. Ali, thank you for your excellent presentation. I just want to ask you one question. Did you find any other studies supporting that we may have a higher fracture resistance of restorations fabricated with CAD/CAM technology, lithium disilicate, or any other materials?
Thank you, Dr. Afra, for your question. Yes, actually, the literature is very rich in studies that proved and shown clearly that the CAD/CAM monolithic ceramic crowns have greater fracture resistance values than the other groups in their studies. However, they utilize different ceramic materials. The one I can recall is a study published in the Journal of Prosthodontic Dentistry, which is a famous dental journal with a very high impact factor. And that study, also the CAD/CAM group was the highest fracture resistance value group. But the material of fabrication was the feldspathic ceramic. So
okay, thank you, Dr. Ali. So now, thank you, Dr. Ali. So now we will move to the second presenter, Dr. Maha Al-Mazid.
Hello, everyone. Maha Al-Mazid, R3 prosthodontic resident. It's my pleasure to present my research under the title, The Effect of In Vitro Aging on the Color Stability of the Cubic and Tetragonal Zirconia Materials. I will start with a brief introduction that there is a 3 generation of the zirconia. First generation was developed over 15 years ago, which exhibited opaque and a lack of the optical properties. So the framework veneered with a suitable glass ceramic, this veneering ceramic have a different coefficient thermal expansion and the chipping occur. To avoid the risk of chipping, the new monolithic zirconia ceramic block are used to fabricate full anatomical crown without layering. However, it cannot be used with a high aesthetic demand anterior area. A new third generation ultra-translucent monolithic zirconia has introduced in 2015 to overcome this limitation and can be used for anterior and the posterior area. It has a large particle size and a cubic face, which make the material more translucent. However, the information regarding the effect of aging on the color stability of the monolithic zirconia, fully stabilized zirconia is lacking. So the question then arises, does the thermal cycling aging affect on the color stability of the third generation zirconia materials? My null hypothesis, there is no effect of aging on the color stability among the 3 types of the cubic zirconia tested comparing to the tetragonal zirconia of the first generation. Moving on, material and method, there is a 40 disc shaped specimens were prepared from the partially centered zirconia block according to the manufacturer instruction with the following distribution: a 10 disc from the first generation and a 10 disc each from the 3 brands of the first generation. The color measurement before aging uses spectrophotometer. Then all the samples were subjected to the 3,500 cycle. After that, the color measurement after the aging used the same technique as described before the aging process. Then the color difference were calculated according to this formula. And one way ANOVA test shows there is a statistically significant difference among the group where the ceramizolid low translucent show the greatest change in the color, followed by Katana, then the ceramizolid, and least change in the color was Zircon XC. So, based on the result of this study, the null hypothesis was rejected. And the color changes in the all 4 tested zirconia, there is a statistically different, but however, there is clinically perceivable change, whereas a delta E less than 3.3. Thank you.
Okay, thank you. So now we have 2 minutes for questions. Dr. May, Dr. Afra.
Assalamu alaikum. Shukran, Dr. Maha. Thank you so much for your wonderful research. It's really quite exceptional, very interesting, a good number of samples. I just want to ask, out of curiosity, do you have any conflict of interest promoting any product over the other? Thank you.
No, there is no conflict of interest.
Thank you. So you promote Zircon XT for your patients to consider with its high aesthetics and fracture resistance, right?
Yes. Right.
Thank you so much. Good luck.
Welcome.
Assalamu alaikum, Dr. Maha. Thank you for your presentation. I just want to ask you if there is any statistical difference between the 3 groups between them. You said the 3rd generation is a significantly difference among the old one, the 1st generation. What about the 3 groups together? You said Zircon XT has the least change, but is it statistically different? I couldn't see any p-value in the presentation.
Yes, Dr. Afra, we use Toki post-hoc test to compare between the 3 material, these 3 material, and show there is no difference between the zircon and the solid. But the katana showed the lower change in the color than the ceramide solid low translucent. So between these 3 material, the ceramide, still this is the least change in the color.
Okay, thank you. Thank you.
Okay, thank you, Dr. Maha. So now we will move to Dr. Hind, our 3rd presenter.
Assalamu alaikum. My name is Hind Abu Haleba. I will share with you my research title about experimental evaluation of cyclic fatigue resistance of 2 nickel titanium instruments after emerging in sodium hypochlorite. Okay. The introduction, with all the advantages of nickel titanium instrument in endodontic field, it appears to have a risk of separation, mainly because cyclic fatigue and torsional shift. Also, the corrosion is an additional factor that maybe limits the resistance to fatigue fracture, which occur during the root canal cleaning and shaping when files come in contact with the sodium hypochlorite. So the aim of my study to assess the resistance to cyclic fatigue of 2 nickel titanium files, 1 curve and blue taper gold after emerging in sodium hypochlorite solutions over several times period at the body temperature. The rationale of the studies, up to this moment, no study have evaluated the effect of emerging in sodium hypochlorite on the cyclic fatigue resistance of 1 curve NiTi instrument, which are recently introduced. The hypothesis, the null hypothesis, was that there will be no difference in the cyclic fatigue resistance between the instruments that are immersed in sodium hypochlorite and the ones that are not. So the study design, the total number of 90 nickel titanium rotary files were used in this study and distributed in the 2 major groups, which is blue taper gold, 45 files, and 1 curve also is 45 files. Each group was subdivided into 3 different groups of 15 each. Group A, which is the control group, Group B, which is 1 minute emerging in sodium hypochlorite, and Group C, 5 minutes immersed in hypochlorite. The methodology, after the preparations, all the files, cyclic fatigue for all the instruments was tested under the continuous clockwise rotations according to the manufacturer instructions. The times was video recorded until the instrument fractures was observed. So the result, descriptive statistic of number of cyclic fatigue to the fractures in the different group shows that significant difference between the 2 groups, the 1 curve group and the blue taper group. Also, there's significant difference between the control group and 5 minute emergings for the both groups. So my conclusions, within the limitations of this study, it can be concluded that the one curve file showed significantly more resistance to the cyclic fatigue failure compared to the Brute Weber code in all the levels. As a control after emerging in 1 minute and after emerging in 5 minutes. Emerging in sodium hypochlorite for 5 minutes reduced significantly the cyclic fatigue resistance for both tested files. Upon this finding, the hypothesis was rejected. And thank you.
Thank you, Dr. Hind. We will move now to our respected judges.
Assalamu alaikum, Dr. Hind. I'm beyond words. I'm so impressed. Each research outshines the other research, but they're all wonderful. I had one comment and one question. The comment was, it's a great, research and definitely promoting the one curve nickel titanium as the best rotary instrument. What would you do differently if you had the opportunity to conduct this research clinically? Thank you.
During the clinic, we try to, of course, we use the sodium hypochlorite routinely because it's the best for disinfections during the treatment. So I will try to minimize the contact between the file and the sodium as much as we can. And if we cannot, of course, we cannot. We stop using for long times because if we continue with the same file, of course, will be fractures, will be assist to the fracture. That's
it. Thank you, Dr. Hind, for your presentation. I just have the question. Did you notice any specific site for the separation location in the shaft, midpoint of curvature? Did you notice any specific area?
During my study, I didn't mention where the fractures is. Also, only we concentrate the fractures, the times of the fractures. We video recorded when it's fractures and when it will be more fast during the 1 minute or 5 minutes. So if we put it for long times during the long times, emerging in sodium hypochlorite will be fracture fast and easy. We didn't concentrate on that.
Okay, what's your limitation? What's your limitation in this study?
Okay, my limitation for this study because I do it full emergence for the file, so I have a galvanic corrosions for the file. So, and if we did it again, we will try to do a dynamic emerging or partly emerge the file. That's it.
Okay, thank you.
Okay, thank you. Now we will move to Dr. Muhammad Al-Ustad. Could you open your mic, Dr. Muhammad?
Okay, is this good, Doctor?
Yes, you can start now.
Good evening, everyone. I am Mohammed Al-Ustaz, R3 prosthodontic resident, and my research entitled With a Vertical Marginal Adaptation and Micro Leakage of Deep Marginal Elevation Compared with the Natural Tooth Structure from 2 Monolithic Ceramic Material. The finish line should be in sound tooth structure. Supragingival margin is always recommended over the subgingival margin. If we have deep subgingival margin, crown lengthening can be a solution, but sometimes it jeopardizes the crown root ratio. So the question that should come to our mind, can we put our finish line on composite? And this is where the deep marginal elevation concept comes in handy. But the research in this field is about onlays and inlays and none about the crown. So the aim of our study is to evaluate the vertical marginal adaptation and micro leakage for lithium diasilicate and zirconia on DME compared with the natural tooth structure. For the material, we had 80 randomly extracted teeth that were randomly divided into 2 groups, which further divided into 4 groups according to the finish line. Enamel, dentin, deep marginal elevation one side and deep marginal elevation 2 side. As for the method, we had 3 steps. Baseline, 500,000 showing simulation cycle representing 2 years of clinical service, and 1,200,000 showing cycle representing 5 years of clinical service. At each point, we soak the sample at ammonium silver nitrate and then expose it to microcomputed tomography to measure the micro leakage and marginal adaptation. For the lithium diasilicate, we found out that the dentin finish line is significantly higher than the rest of the groups, whereas the enamel, one-sided deep marginal elevation and 2-sided the deep marginal elevation had no significant difference. And this result was seen in the baseline 500,000 cycle and 1,200,000 cycle. In terms of micro leakage, dentin finish line showed significantly higher micro leakage than the enamel and the rest of the group, followed by the enamel, which showed significantly higher micro leakage than the deep marginal elevation 1 and 2, and no significant in the later groups. As the result for the zirconia, we found out the enamel and dentin finish line had no significant difference, but both of them had significantly lower vertical marginal gap than the 2 DME marginal elevation. As for the micro leakage, enamel shows significantly lower than the rest of the group, followed by the dentin, and then the deep marginal elevation 1 and 2 show significantly higher than the rest of the group and no significant difference. As for the zirconia, 12 out of the 40 zirconia got debonded during the showing simulation, so the conversion at the 500,000 cycle and 1,200,000 cycle wasn't applicable. As a conclusion, lithium diasilicate on composite finish line has a better vertical marginal adaptation than dentin and had comparable result with enamel. As for the micro leakage, showed better. As for the zirconia, on the other hand, zirconia showed better vertical marginal adaptation and lesser micro leakage than the deep marginal elevation. This study generated a very encouraging result to use the glass-based ceramic with the deep marginal elevation and composite finish line. But a conclusive recommendation to employ this procedure in daily clinical practice cannot be recommended at this point until a very high level of evidence in the form of a clinical trial is available. Thank you, and please feel free to scan the reference and to contact me at any time.
Thank you, Dr. Muhammad. We have 1 minute and 30 seconds for questions from our respected judges.
Thank you, Dr. Muhammad. Wonderful research. It's a little bit confusing according to the finish line, what better restorative material to use. So for lithium disilicate would be better because it has less chance of the debond that happened with the zirconia. Can you elaborate on that, please?
Yes, the lithium diasilicate is better to be used in composite finish line when we compare it to dentin, but it's better to use it in enamel. And due to the debonding that happened in the zirconia, lithium diasilicate is better to be used with the composite finish line.
Thank you so much.
You're welcome, Doctor.
Thank you, Dr. Muhammad. I just want to ask about your results in lithium disilicate over zirconia regarding the deep marginal elevation. Is there any studies going in line and supporting your findings?
Unfortunately, there are no study currently in the literature studying the marginal adaptation and micro leakage in crowns. All the study in the literature is studying the onlays and inlays. And actually the study is huger than this. We tested almost 8 parameters in each group.
Okay, the other studies for inlay and onlay, what were their findings?
The finding was in terms of marginal equality, it showed a better result than dentin as the finding of the crowns.
Okay.
But in the onlays, we don't use zirconia. We use only ceramic, glass-based ceramic. So they saw that in comparison with the dentin finish line, the composite or the deep marginal elevation had the better results.
Thank you, Dr. Muhammad. So we will move now to Dr. Shadil.
Thank you for giving me this chance to present my research, cytokine markers analysis for implant sites in Saudi subjects with and without diabetes mellitus. The link between oral health and systemic health is a big and interesting field of research. We chose diabetes due to its prevalence in our society. 23%, which is almost 1/4 of our population, are diabetic. The aim of this study was to assess the following: clinical findings of propping depth, leading on propping, and amount of present keratinized tissue or dental implant, and to assess the per-implant cervical fluid levels of interleukin-1 alpha, interleukin-1 beta, interleukin-6, interleukin-8, and diabetic and non-diabetic partially edentulous Saudi Arabian subjects who had dental implants. For materials and methods, a total of 23 subjects, 16 diabetic and 16 non-diabetic subjects who had dental implants, and periodontic department clinics of Riyadh University were included in the study. Diabetes was confirmed by the patient's last HbA1c reports. The exclusion criteria were any other systemic conditions, systemic antibiotic or steroid intake within the last 3 months, a history of periodontal treatment within the previous 3 months, and smokers. Pre-implant cubical fluid samples were taken using paper point, then subjected to centrifugation, followed by PCR assays for interleukin-1 alpha, 1 beta, 6, and 8. After that, clinical periodontal parameters of pre-implant propping depth, feeding on propping, and amount of keratinized tissue were recorded. The results showed that no significant difference was found between diabetic and non-diabetic patients in the amount of keratinized tissue, while the diabetic subjects had more significant bleeding on propping and propping depth than non-diabetic patients. 87% of diabetic patients had bleeding on propping, while the percent in non-diabetic patients was 37. Here you see the level of all 4 interleukins in diabetic and non-diabetic groups. Only interleukin 6 levels were found to be significantly higher in Saudi Arabian diabetic subjects compared to non-diabetic subjects. Interleukin-1 alpha, interleukin 6 were significantly higher in subjects who had bleeding on propping. A positive correlation found between increased propping depth and increased levels of interleukin-1 alpha, interleukin-1 beta, interleukin 6, and interleukin 8. As a conclusion, hyperglycemia could be an important factor in the development of biological complications of dental implants, especially in poorly controlled diabetes. Further research with larger sample size and subgrouping to controlled and uncontrolled diabetes are recommended. Thank you.
Thank you, doctors. Now the mic will move to our respected judges.
Thank you, Dr. Rashad, and very interesting research. I had actually 2 questions. What is the literature out there that supports your study? And the second question is, or the second comment is, you can propose a marker to diagnose people walking into the clinic according to the interleukin levels, if they are candidates for implant or not, and whether their prognosis will be a good prognosis or a poor prognosis based on their interleukin levels and their gingival perclavicular fluid. And I think it's a wonderful research, and I think you can continue with this research as your interest, your clinical interest. And thank you so much.
Thank you, Dr. May. For your first question, most of the literature talk about interleukin levels in periodontitis patients and the different interleukin levels after performing a treatment, a periodontal treatment. There is not much literature about interleukin levels around dental implants. And for your second question, unfortunately, the cost of such a test is a barrier. I would like to have one day we can perform such a test, like a case risk test with acceptable cost for the patients.
Thank you, Dr. Shadin, for your nice research. I'm asking about the recommendation. What's your recommendation at the end of your study?
I recommend to go for larger sample size and going for subgrouping. If you go for larger sample size, you can subgroup the diabetic patients to controlled and uncontrolled diabetic patients, so you can get a better idea.
Okay. The implication of this study on our clinical practice. What do you think can we implement this study in our daily clinical practice?
Actually, the study is in the field of prevention, and we have to pay attention, and we have to do our job not only for surgeries and performing big surgeries like implants, sinus left, bone and tissue grafts. We have to pay attention for disease prevention.
Okay, thank you. Thank you very much.
You're welcome.
Thank you, doctors. Now we will move to Dr. Hassan.
Yes.
Yes.
Assalamu alaikum wa rahmatullahi wa barakatuh. With you, Dr. Hassan Al-Alawi. I will present my research entitled of Functional Appliance, Effectiveness and Stability of Treating Class 2 Skeletal Malocclusion, a Systematic Review. Let's start with the background. With regards to the malocclusion, are the third worldwide oral pathogen, class 2 considered the most frequent condition in orthodontic practice. There are many strategies for correction of class 2 malocclusion, such as a functional appliance. These appliances have the maximum effect when applied in early life while the jaw is still growing. Our objective from this research to assess the literature on the effectiveness and determine its stability result from the fixed and removable functional appliance. Our study review methods, a review of the literature was carried out in the review of the most important point of the other systematic review using the preferring reporting item for systematic review and meta-analysis Prisma. For recent studies, 7 search engines were utilized up to year December 2019. The inclusion criteria were children less than 16 years old with skeletal class 2 malocclusion and overjet greater than 5 millimeter. Any type of fixed removable functional appliance, randomized or non-randomized controlled clinical trials. The primary outcome were measures of skeletal, dentoalveolar, and soft tissue correction. Our search question was developed using format comparison or result. Our summary of the article, the general characteristic of the 10 included article, reporting 471 cases, 244 of them were male, and 227 were female. Among the studies, the average age was 12. The most of the patients had class 2 malocclusion division 2, while the remaining 3 studies class 2 division 2. Our result here, we can see result of each study indicated that the patient treated with twin block appliance show significantly greater reduction of overjet, while there is a decrease in edge angle in herpes appliance. Twin block and forces resistant device the same rate of the success, and twin block overcome any other removable appliance such as a bionator at high significant difference in the made in A and B angle and anterior lower facial height. Moreover, twin block represent change in S and A angle, no change in S and B angle comparing with headgears. Our conclusion here from the done review, it can be concluded that the key difference between fixed and removable functional appliance related to the ability to fix the type and secure the component. However, there will be high rate of breakage and more emergency visit. Conversely, that removable appliance may be associated with excessive vertical bite opening and interference with normal function of the mandible movement for long time use. Thank you very much.
Thank you. Now we will move to our Dr. Sanel and Professor Mohammed Al-Umari.
Assalamu alaikum, Dr. Hassan. Thank you for this excellent study. It is strong, and also there is a strong conclusion. Can you elaborate more on your conclusion? I mean, when you did the inclusion criteria, sure there was some weak articles and you took it in consideration in your inclusion. Now, regarding this strong conclusion that functional appliance is still a good one, even if it is removable or fixed. Can you elaborate more?
Yes, Doctor. We are doing a precise here in this systematic review. We choose our article based on the long list of inclusion and exclusion criteria. Our exclusion criteria for studies that involving patients with craniofacial syndromes or cleft lip or palate will be excluded. Any enamel studies, any studies that involve patients with a class 2 malocclusion treated with extraction or orthodontic surgery or published before 2014. We are doing age, children, our inclusion is age group of the patient should be children less than 16 years with skeletal class 2 malocclusion and with overjet greater than 5 millimeter. Here we found that in the whole study comparing with the fixed appliance, we found that the removable appliance overcome in situation for removable appliance twin blocks. We found that it is a greater reduction in overjet and overcome fixed and all removable appliance.
Thank you very much. Thank you.
Okay, so now we will move to the second presenter, Dr. Abdurrahman.
Good evening, everyone. I am glad to present my presentation today. Our topic is the effectiveness of electronic pulse of tissue vibration compared with topical anesthesia in reducing the pain of injection of local anesthesia for exudontia in adult. The supervisor was Dr. Riyadh Salma. Many doctors wondering which best way that we can reducing the pain in the local anesthesia. So we thought that if the vibration can lead to that effect, so our null hypothesis was the electronic pulse tissue vibration does not reduce the pain of injection of dental local anesthesia in adults. The purpose of this study was to evaluate the effectiveness of vibration device on the pain of local anesthesia injection, onset of action, and physiological changes. Trial design and ethical approval. A prospective randomized controlled clinical trial using a split mouth crossover design was implemented. The study protocol was registered at clinicaltrial.gov. For more information, you can scan the barcode. Eligible candidates were given the choice to participate in this trial. All of the included patients signed informed consent. We used modified dental anxiety scale questionnaire, which is better than CORA because it contained the 50 question that's related to dental anxiety. Visual analog scale was used to determine the pain out 1 to 10. Man mentally U test was used and critical Willis test. Data analysis were performed using IBM SPSS version 2020. The next video will show how we apply the device on the injection. Basically, the device working 5 to 10 seconds before we start and during the injection. Each patient received 2 local anesthesia injection for routine bilateral same jaw posterior exodonia performed in 2 visits. Between each visit, 3 weeks with a watch period. Control injection was done using a conventional local anesthesia with application of 2 gram anesthesia, and the device was applied as retractor without switching on. Experimental side was done without pre-application of topical anesthesia with aid of a vibration device. Moving to the result shows that the pain at the conventional way at the penetration was 7, comparing to 4 with the vibration device. Pain during the injection was 6, with the device was 2. The pain comparing with the buccal palatal and inferior alveolar nerve block. On the buccal side was at the penetration 7, with the palatal and inferior was 8, with the vibration was 3 and 4 for each palatal and inferior, which almost the half. Pain during the injection was 6 for each palatal and buccal, and inferior was 7, and almost was the half during the vibration device. These results supported with the heart rate with 7 in the conventional vibration at 4 and duration 3 and vibration at 2. That leads us to the conclude that the vibration device was clinically and statistically more effective than topical anesthesia in reduction of dental injection pain. I just want to mention that there's study done before on the children. The result shows no effect. And thank you.
Thank you, Dr. Abdulrahman. Now we will move to our respected judge, Prof. Umari. Dr. Sunil.
Dr. Abdulrahman, thank you. It's excellent study. My question regarding the age group. I mean, how many age groups you have for this study?
Basically, doctor, we study about from 18 up to 40 because we used who want to make them that most be healthy. So that's why we use about from 18 up to 40 to avoid that we have like a diabetic or hypertensive, some other factor can affect our result.
How you calibrate the clinician, operation process?
Sorry, doctor, I did not hear you.
How you calibrate the clinician? Is it one clinician for all who did all?
We already practice as two person that give an injection. We already divide ourselves to 2 groups. Each group contain of 2 researchers. One of them give the anesthesia, the other monitoring the data, and we use also oximeter to monitor the heart rate with the oxygen level to make sure that the patient says the exact pain what he feels. So not he feel, for example, if patient pain 1 and the heart rate was already high. So we know that there's something wrong.
What about the exclusion criteria?
Exclusion criteria, any patient was not having any anesthesia before. So our inclusion criteria was supposedly patient have done local anesthesia before. So he has previous experience and less than 18 and if has any diabetic or any, so for example, medical compromised patient.
Okay. Some of the patients denied the experiment or they continue with you?
Some patients did not continue because the appointment was 3 weeks after. So our job was just to monitoring. It was really, to be honest, difficult to monitor and take each number with the student and the internship. So almost we spent almost around 7 months to finish just sampling.
How many patients they are denying?
We did around 166 patients and we gave around 332 local anesthesia.
Thank you very much.
Thank you very much.
Dr. Mohammed Rayyan.
يعطيك العافية. Thank you very much, Dr. Abdurrahman. This is a clinical trial, controlled clinical trial, so it offers really strong evidence. I just want to ask you, how did you calculate the sample size? How did you know that this sample size will give you adequate power of the results?
To be honest, Doctor, we use اللي هو المان ويسلي تيست اللي هو أساسا معمول للنون بارامتريك تيست للنون هايبوثيسيس، فمن خلالها أخذنا الباور سامبل.
Okay, can you list or report any limitations for this study?
Actually, دكتور هو ما كان في أي limitation عندنا من ناحية الستدي. إنه ما واجهنا في except we exclude the patient did not continue with us or disapprove. We did not continue with them or did it for them.
Okay, thank you very much.
Thank you. So now we will move to Dr. Fatima.
Greetings, doctor. My name is Fatima Al-Ahmed. Today, inshallah, I'll present our research evaluation of medicative endodontic material in primary molar bulbotomy, a systematic review. Our introduction, one of the most important purpose and aims in pediatric dentistry is to maintain the children's primary teeth anatomical and functional condition until their physiological exuvation, eruption, and permanent teeth. Bulbotomy is one of conservative therapeutic alternative which is aimed to remove the infected coronal bulb and capping it with biocompatible material in order to fix and stimulate the repairing of the remaining vital bulb and maintain the function and the vitality of the remaining radicular bulb. There are several material and medication that can be used in a primary molar bulbotomy. These medications should have the desirable antimicrobial effect in order to reduce the bacteria as well the pain and swelling after treatment. Scientists work around the clock to find the alternative material which is perceived the high efficacy and high safety. It is important to compare between the different types of mediactive endodontic material to evaluate the efficacy, safety, and stability. The aim of this review is to systematically assess the literature evaluation of a different type of mediactive endodontic material and to compare it between them stability of the treatment of primary molar bulbotomy. Methodology, protocol, and restoration. In this systematic review, we depend on a guidelines provided by Crohan Handbook, a systematic review. And in this review, we reported one of the base of the preferred reporting item for a systematic review and meta-analysis, information source and search. In this review, we collected all studies conducted from 2010 to 2020, different electronic database, primary molar bulbotomy, medicative material, stability, and evaluation are the most keywords that we used. Eligibility criteria and study selection, 11 articles was included in this qualitative synthesis of the present review. After identifying the proper study, we removed the duplicated and tested each study alone. Only the study that is randomized or non-randomized controlled clinical trials are included in this research with patients less than 12 years old and undergone with the primary bulbotomy using any type of mediactive endodontic material would be used in our review. Data item, move over to identify the possible factor that is change the result. We have categorized the patient-related age and sex and the treatment-related type of mediactive material. This is our systematic review and meta-analysis. Here are the general information results of each study. Our results, one study were retrospective, 2 were prospective, and there was 8 randomized clinical trial. There is no no case report or cross-sectional study included in this review. Among the 7 studies reporting the age, the average of the patient age was 6.5. The first reach out result in this review that all study failed to find any significant advantage of one mediactive substance over the other, except for the advantage of biodentin and MTA over the calcium hydroxide. For the success of biodentin 100, for macrosol success rate was 96.4, and for the MTA was 89.4 for that period of 24 months. Calcium hydroxide group are the lowest success rate in this study, although we recommend the uses of MTA, biodentin, and formacrosol over the calcium hydroxide and ferric sulfate.
Thank you, Dr. Fatma. Because the time, you extend the time, we will have one question from our judge. Dr. Ansari, Dr. Sunel.
Yeah, it's a very nice presentation, by the way. Okay, I really respect for the hard work what you have done and getting the results. I think you can go ahead with this and still go further into it, and it helps you in your publication also. Regarding one of the question I want to ask you regarding the PRISMA guidelines you have taken, is it the recent ones, because we have the 2020 one, or you had used the older guidelines?
Well, we use all the conducted research that we use, the 11 article. It was exactly from 2010 until the early of 2020.
Okay, no, I'm asking about the systematic review, the guidelines, what you are using it. Okay, so kindly update it to 2020 when you are getting it published. Okay, but otherwise your presentation and everything, it's very good. Okay, good luck for you.
Thank you so much, Doctor.
Thank you. So now we will move to the second presenter, Dr. Ruwaida.
Assalamu alaikum. I am Riyadh Al-Arshad, dental intern at Riyadh Al-Almi University. I will present our research, which is about locator attachment, patient satisfaction, success rate, and peri-implant health, a systematic review. As we know, one of the main complaints of patients with conventional complete denture is the instability of lower denture. Adequate retention should solve this problem, obtained by selecting attachment for denture stability. An attachment is defined as a mechanical device for fixation, retention, and stabilization of a prosthesis. It is connector consisting of two parts. One part is connecting to a root tooth or implant, and other part to prosthesis. Our aim is to address treatment outcomes for locator attachment system for implant-supported upper denture compared to other attachment systems in terms of clinical survival rate, level of patient satisfaction, and peri-implant consideration. The collected articles from databases were proceed using PRISMA guideline. After we removed duplicate and applied exclusion and inclusion criteria, we include 14 studies in qualitative analysis, while there were 8 studies included in meta-analysis. There were 5 studies reported clinical survival rate. All of them reported a 100% survival rate at 1 year. Regarding patient satisfaction, all studies reviewed showed large variation in patient satisfaction. According to peri-implant health, we did meta-analysis for bone loss and probing depth. For bone loss, the mean of bone loss for locator attachment was higher than bone loss of different attachments used in this study. However, there was greater range of confidence interval and higher heterogeneity. For probing depth, the mean of probing depth for locator attachment was lower than probing depth for other attachments that include in our study, and heterogeneity decreased. We can conclude our study in several points. Survival of abutment implant is not influenced by the type of attachment used. There are great variation of patient preference for attachment type. The studies reviewed suggest that the practitioner should discuss the type of the attachment and benefits for each type with the patient. You can find our reference by screening this code, and thank you.
Okay, thank you. So now we will move to our respected judge.
Thank you, Ruwaida, for the nice review. May I ask to you to give us 1 or 2 examples for excluding full text articles based on risk of bias assessment?
Will you please repeat your question, Doctor?
What was the most common reason to exclude full text articles from your review based on risk of bias assessment? The exclusions criteria.
No, we include the weak study and moderate study and strong study in our research. We didn't exclude it.
Okay, you didn't do the evaluation for the strength?
No, we did evaluation of the strength of the study, and there was weak studies and moderate study and strong study. We included all of them.
Okay, thank you.
You're welcome.
Thank you, Doctora. This is important review, and there is lack of systematic reviews and meta-analysis on locators. I want to ask you, you mentioned that you selected 5 studies and the survival rate was for 1 year was 100% in all of them.
Yes.
Why especially 1 year? All the 5 studies only monitor
No,
the survival rate on 1 year, or?
According our inclusion criteria, we include the studies have 1 year at least follow-up.
Yes. So what about the 5-year survival rate, for example?
That at least 1 year.
Okay.
For at least
My second question, why did you search for these survival rate, probing depth, etc.? How about the retention of the locators?
I think we need to do more studies about it.
Okay. Your conclusion was general. Can you give us a more concise conclusion which is driven or from the findings of your study?
Because
the aim
there
of your
was
study is to look for the outcomes of the locators. So what is your conclusion?
there was great variation and there is large confidence interval rate. So we have to do more studies that have unified tests and experiment to have more clinical significance.
Okay, Doctora, thank you very much.
We have limitation. You are
Thank
welcome.
you. Thank you, Doctor. So now we will move to Dr. Basil Ghamdi.
Good day, everyone. My name is Basil Ghamdi, dental intern at Riyadh Alm University. I will present our research topic, the effect of peridental treatment on glycated hemoglobin levels in diabetic patient, a systematic review. Introduction with regard to the clinical relation between peridental disease and the metabolic control of diabetic patient. We must understand that peridental treatment is an additional modality of the pharmacotherapy and lifestyle changes that diabetic patients go through. To assess the clinical significance of peridental therapy on the metabolic control of glucose level, the glycated hemoglobin levels are used to compare the peridental therapy's effect to the effect of additional pharmacological drugs. The study review method, a review of literature was carried out in a review of the most important point of the systematic review using preferring reporting items for systematic review and meta-analysis. For recent studies, 5 search engines were utilized up to the year 2019. The including criteria were patients with type 1 or type 2 diabetes mellitus diagnosed with the peridental disease regardless of the classification. Peridental treatment with or without using medical intervention, and the studies with changes in glycated hemoglobin. In the summary here, we can see the treatment method here used in 10 articles, surgical and non-surgical, with or without adjunctive antimicrobial therapy, with average of 3 to 4 month follow-up. And the result we can see here also improvement of hemoglobin level in all 10 articles after peridental treatment. Conclusion, patients suffering from peridental disease are also prone to complication from diabetes mellitus, as it has been shown that not only that diabetes mellitus is a risk factor for peridental disease, but that peridental disease in turn could affect the control of blood glucose level. There is a markedly significant effect of peridental treatment on the improvement of hemoglobin percentage in diabetic patient, though the effect size is very small. Thank you all.
Thank you. We'll move now to Dr. Sunil, Dr. Ansari, our respected judge.
Thank you very much, Dr. Basil. I just have one question and one recommendation. Regarding my question, what type of screening method did you use to screen all the articles? Which guidelines?
For the inclusion?
Yeah, and exclusion.
Yeah, for the, yes. For the inclusion, for the data, we use 5 engine for the search in English language. Group research was selected manually, and the total of comparative analysis of secondary analysis was carried out in different forms of pattern analyzed. For the exclusion criteria, have a study provide the result of heterogeneity analyze the outcome indicator for hemoglobin test improvement comparisons between the therapeutic intervention percentage and the control group.
All right. Thank you very much. Good presentation.
Thank you.
Dr. Sunail, do you have a question?
Yeah, thank you so much. Dr. Ansari has asked the question regarding it.
Okay,
thank you.
So now we will move to the next presenter, Dr. Amuna. Open your mic, Dr. Amuna. Welcome, salam. Yes, we can start.
Is it clear?
Yes.
Assalamu alaikum wa rahmatullah. I'm Muna Lanizi. I'll present our research on behalf of our group and our supervisor and mentor, Dr. Sultan Shamri. Our research talks about the evaluation of light curing intensity output and students' knowledge among dental schools in Riyadh City. As we all know, the demand for bonded restorations became increasingly higher, therefore we depend more on light curing units. However, if the polymerization of the restoration is inadequate, this could result in micro leakage, post-operative sensitivity, and even secondary caries. We had two aims. One is to evaluate the dental students' knowledge on light curing units, and two is to evaluate the intensity of light output using the Dimetron LED radiometer. It was a cross-sectional study. We collected 325 questionnaires from dental interns and students all around Riyadh. We also measured the intensities of 182 LED curing devices from these prestigious colleges and universities all around Riyadh. The data was analyzed using a one-sample test. The p-value was less than 0.05, which makes it statistically significant. As for the curing devices that were measured, out of 182, only 69 had adequate intensity, which makes up the percentage of 37, and 50% were marginal intensity and 12% were inadequate. However, the questionnaire findings were analyzed using SPSS. We asked the students what is the minimum wavelength of light curing units, and 40% answered 400 nanometer. We also asked the students what is the optimum distance between the tip of the curing unit and the restoration. 70% answered as close as possible without touching the surface. However, when we asked our students increasing the time of curing or increasing the light intensity and its negative effect on the pulp, 55% answered that no, it does not affect the pulp. We conclude that intensities from different schools were significantly different than the adequate intensity, which is 850. We also concluded from the questionnaires that dental students lack knowledge about certain facts about light curing units and their correct use, and there is a gap in research when it comes to light curing units, especially in Riyadh City, and this gap needs to be filled considering how essential light curing units are in our day-to-day practice as EPs. Thank you very much.
Okay, so now we will move to our respected guest, Dr. Mohammed Rayyan, Dr. Basil.
Thank you, Mona, for the nice topic and the nice design of the study.
Thank you.
My question regarding the 850 microwave. From where did you get this marginal or optimum level of light? Is it from manufacturer or from the literature or
from the literature? We had many articles to reference by.
Okay, may I suggest one suggestion for the future, just to test or to conduct a similar study, testing presence of a plastic leaf over the tip of the light that may affect the intensity of the light.
Yeah, that's a good topic. Thank you.
Thank you, Doctora, for this important study. May I ask you about, did you consider that there is different brands and different types of light curing units? And also the ones which you tested, did you ask about the age of the unit, about the protocol of maintenance? Did you collect this information and try to relate it to the scores or the test which you done?
Actually, no. We did ask about the age. The company, every college or university had a different company, so we couldn't really gather company names. However, the aid we did ask, the highest intensities were the newest light curing units, and the lowest intensities were the oldest. So I think there's a lack in maintenance when it comes to the age of the light curing unit.
Yes, I think this is important factor, and based on that you can make a certain recommendation, but you need to prove it by statistics. Another question, was there a difference between universities? Did you compare between different universities? Maybe there are certain variables that is involved for having knowledge better in one university than the other?
We did compare between the universities, but the comparison was more of the age group of the students or their level of academic rather than the university that they're from. And we found that the younger the students were, the more knowledge they had when it comes to light curing units, surprisingly.
Okay, Doctora, thank you very much. Thank you.
Okay, thank you. So now we will move to Doctora Safa.
One of the main reasons to replace restoration, it's being a fracture. Internal flows is expressed in the fracture toughness factor. Therefore, testing the fracture resistance of the restorative material is very essential for the long-term success of the material. The aim of our study to compare the fracture resistance of 4 different recently introduced composite restoration after thermocycling. Material and methods, we have 80 composite disc was fabricated using a round metal base, as you can see in the picture, to standardize all sizes. A total of 4 groups were divided equally, having 20 discs for each group. Group 1 had been fabricated using Filtic Universal Restorative ZX 350 XT. Group 2, 3, and 4 were done as follow: Filtic Bulk Fill Restorative, Sonic Fill 2 from Care Company, and Harmonized Composite from Care also. All samples were then bought for thermocycling for 500 cycle through a water bath at 5 and 55 degrees. After thermocycling, samples were placed or were stored in an incubator for 24 hours. And after that, all samples were placed in a custom-made testing jig and tested on a universal testing machine instrument. Statistical analysis, mean and standard deviation of the fracture resistance were calculated. One-way analysis of variance ANOVA and post-hoc Jockey test were used to determine the differences between the groups. Statistical software SPSS version 22 was used for analysis, and the significance level was set at p-value less or equal 0.05. As we can see here in the table, the mean fracture resistance values of the specimen in the bulk fill group were found to be superior when compared to all other groups. The least mean fracture resistance value was calculated in the harmonized group. Conclusion, within the limitation of our study, the experimental group's bulk fill composite showed the highest fracture resistance. Statistically, a significant difference wasn't seen between the Filtic bulk fill and Filtic Z350 XT. Thank you so much.
Thank you. So now we will move to Dr. Mohammed Rayyan, Dr. Basil, our respected judges.
Thank you, Safa, for the nice presentation and the study. Kindly please mention the dimensions of your samples, and did you do any type of finishing and polishing for these samples?
The dimension was 10 millimeter, the diameter.
And thickness?
Thickness was, as I remember, 2 millimeter.
What about finishing and polishing? Is it necessary to perform finishing and polishing, or just?
We didn't do finishing and polishing. We just put the sample on the metal round base, and we put the glass slab over it, and we just removed the discs.
What is the limitation of such a study if compared to a clinical situation?
The limitation of our study, as you know, clinical situation cannot be well simulated in vitro, but we perform thermocycling to better simulate the clinical environment and to increase the accuracy of the result. I think further study are required on other type of bulk fill composite and also use different bonding agents.
Thank you.
And also clinical study required to obtain reliable results.
Doctora, thank you very much. Can you tell me, you had 4 groups. Did you have a control group and test groups or?
No, we don't have a control group. We just compare between these 4 composite restoration.
And why did you choose to compare these 4 types? What is specific about them?
We want to see the fracture, which composite restoration is more fracture resistant than other. Which one is we can use it for as a bulk fill in the posterior teeth, in for example in deep cavities.
Okay, and the selection of dimensions, you said 10 millimeters diameter and 2 millimeter thickness. Based on what did you select these dimensions? Did you follow a specific standard or previous studies?
We see other studies, they use many bulk fill composite, but we didn't see on harmonized, but only on other bulk fill composite.
And did you compare your results with similar studies?
Yeah.
What is the similarity or dissimilarities?
Many studies, the same result for Filtec Z350XT, but about the harmonized, many study talking about the shade and color. I don't find the study talking about the fracture resistance of harmonized, because it's a new composite.
Thank you very much. Thank you, Doctora.
Thank you. So now we will move to Dr. Ala.
Hello, everyone. My name
Yes.
is Ala. My name is Ala Al-Qarra. Today I'm going to be present our research title is the effect of 2 different bleaching technique on fracture toughness of 2 bulk fill composite material in vitro study. There is evidence that bleaching plays a crucial role in change the fracture toughness of composite and tooth structure and other materials. The study was done to evaluate the effect of different bleaching technique on fracture toughness of 2 bulk fill composite material. As you see, this 2 bulk fill were tested, Filtec bulk fill and tetric enseram using this study. Also, 2 concentration of bleaching agent were tested to check the fracture toughness, hydrogen peroxide and carbamide peroxide. 36 specimens of each composite disc was finished and polished using sulfex, dividing into 3 groups for each bulk fill material, 12 discs for the control group, 12 discs for home bleaching, and 12 group for 12 discs for offset bleaching. To get an accurate result, according to the statistician advice, the minimum sample could be used in every group is 10, but in this study, 12 discs were used to assure the sample is normal distribution. The result was analyzed using independent t-test. About the result, no significant difference in fracture toughness between office and home bleaching in both tetric enseram and Filtec. Many significant change in enamel properties by the use of bleaching agents have been studied in the past, which considerably decrease mechanical properties. Resin composites are now widely used for all type of restoration, and fracture toughness is one of the most important mechanical properties as they considered to be a indirector of the ability of the resistant failure under load. The fracture toughness of two test bulk fills, الcomposite resin, للتترك انسرام وللفلتك was no effect after the bleaching. بالcarbamide peroxide وبالhydrogen peroxide. At the end, we would like to thank Dr. Maggie Khoderi for the research course and specific writing. And thank you.
Thank you, Ala.
Yes.
Did you compare in your conclusion that, did you mention the results of control groups?
The results of the control group, the results already, there is no significant change.
Between control and the study groups?
Yes.
But you select your topic based...
We have a change only in the on the value.
But was not significant?
Yes, not significant.
You based your selection of the topic based on the evidence that there is some enamel change when applied to a bleaching, or composite structural change when applied or when bleached?
Again, please.
You based your selection based on the evidence that there is enamel change or composite change?
Composite change.
Chemically, did you read in your literature what is the chemical change that could happen when the composite restoration are bleached?
Chemically?
أيوة التغير الكيميائي chemical change اللي بيحصل في الكومبوزيت.
No, we check only the fracture toughness. We use the insert and universal testing machine to check the fracture toughness only.
Yes, do you hypothesize that the composite could be affected by the bleaching regarding the fracture toughness? Yani, evidence, what was the previous evidence?
Yes, because
How the previous evidence mentioned that there is a change in the fracture toughness of composite when bleached?
No previous
evidence.
Yes.
Okay, thank you.
No previous. Also, we talk about this topic because there is not many research available about this topic.
Thank you.
دكتورة يعطيك العافية. Please, you selected to talk about or to investigate the fracture toughness.
Yes.
Yes, but what was the unit? How did you calculate the fracture toughness?
Using the independent t-test.
This is the comparison, but the numbers which you have got from what machine did you use to test the fracture of the composite?
Insert and universal testing machine.
Okay, and the numbers are in which unit, which you have obtained?
Newton.
Okay, fracture toughness. What is the unit of fracture toughness? You need to use an equation in order to calculate the fracture toughness out of these numbers. Because I didn't see any unit on the chart, and I saw that the numbers 1,000 and above. So I assumed that this is Newton, but this is not the fracture toughness. So why did you choose the term fracture toughness, and then why you didn't calculate it?
We calculate because we don't have a significant difference. That's why we didn't. I didn't put it, but I have it already. But because I can't put more than 6 slides. That's why I didn't put it here.
Okay, Doctor. I noticed you didn't put references, or you did?
No.
You didn't use any references?
No, I use 30 references.
Okay, Doctor. Thank you very much.
Okay.
We will move now to the second presenter, the next presenter, Dr. Reem.
Assalamu alaikum everyone. I'm Reem Al-Harbish, a dental intern in Riyadh Al-Almi University. I will be presenting on behalf of my colleagues Our research is proudly supervised by Dr. Abdurrahman Safan. The topic of our research is knowledge, attitudes, and practices towards COVID-19 in a Saudi Arabian population. It's a cross-sectional study. On December 2019, World Health Organization Regional Office in China was informed of cases of pneumonia of unknown cause detected in Wuhan city. In Wuhan, China, the humans were affected via exposure to animals. After that, human-to-human transmission happened. On 30th of January 2020, World Health Organization declared the COVID-19 as the sixth public health emergency of international concern. Saudi Arabia recorded the first confirmed case of Saudi Arabia. Our objectives to assess the knowledge and develop an educational plan for Saudi Arabian population. Provide data to the researchers since no published researches in. Our methodology is a cross-sectional survey study. Survey distributed in all regions of Saudi Arabia through and Fisher's exact test used to test the association between demographic variables, knowledge, attitude, and practices towards. P-value was considered as statistically significant, SPSS version 25 used to analyze the data. Conclusions supported by the results, 6,000 participants participated in the study. 85% reported awareness of the virus. 79% believe that the virus leads. The Saudi population is aware of attitude and practices of prevention as well as the mode of transmission. Our findings indicate an increasing in community epidemic awarenesses since 2000. Efforts orchestrated by the Ministry of Health were efficient, with a noticeable impact on the public education towards increasing awareness among the Saudi population. We can provide baseline data to the government and other health associations. We must have a good knowledge of how the population think towards such a pandemic disease and what are the precautions that they take. Accordingly, we can build a preventative plan in the hospital for our patients. And thank you.
Well, thank you. Now we will move to Prof. Al-Umari, Dr. Ansari, our respected judges.
Dr. Arim, thank you for this baseline study. It's important study for the kingdom. The question is, have you taken in consideration to distribute the questionnaire according to district area?
Sorry, again?
Have you taken in consideration to distribute when you distribute the questionnaire, have you taken in consideration the district area, for example, north, south, middle, or you send it just randomly to 6,000?
No, actually, we asked from which region you are in Saudi Arabia in the survey.
No, have you I mean, taken that during the study design or later on when they respond?
No, from the beginning. From the beginning, we targeted all of the regions.
Okay. Now there is an update. You mentioned that the incubation is 14 days. What is the recent update in this pandemic?
Actually, this survey was taken beginning of the 30th of March and by 1st of April. So we the update 10 days. It was actually 2 days. 2 weeks, I think. The updated 10 days.
Mm-hmm. Okay. I mean, regarding the 6,000 respondents, all of them they responded to you, or the sample size was bigger than this when you send the questionnaire?
No, actually, these are all of what we collect.
Okay, thank you.
Thank you.
Dr. Ansari?
Yes, did you face any limitations while conducting this study?
Any limitations, like what you mean?
Any problem, any hurdles faced during the study?
Yes, I mean, we hope that we get a larger sample size since Saudi Arabia population, but we get 6,000, which is good and efficient for all of the regions in Saudi Arabia.
All right, thank you. Okay, thank you.
Thank you, doctors. Now we will move to Dr. Jadail.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Jadail Luhabi, a dental intern at Riyadh Almmy University. And on behalf of my colleagues, we are delighted to present our research title, Relationship Between Body Mass Index and Dental Caries Among Patients of Riyadh Almmy University Clinics. Dental caries is a chronic and a multifactorial disease with many risk factors, one of them being weight. The global burden of disease estimated that oral disease affected half of the world's population, with tooth decay and permanent teeth being the most prevalent. While there are several methods for calculation of dental caries, the FMT index is one of the most common. BMI is a screening measurement that indicates the risk of disease and is calculated through this formula. Several studies have found that there is a relationship between body mass index and dental caries, but not many were conducted in Riyadh and not many were conducted among adults. Therefore, our study aims to determine if there is a relationship between body mass index and the FMT index among the Riyadh al-Ilm patients. Our study was a cross-sectional study which was conducted at Riyadh University clinics. The patient data was collected through questionnaires and examination after obtaining an informed consent. Our sampling technique was a cluster random technique, and dental caries was diagnosed according to WHO and the MFT index. Toothbrushing was divided to either regular, which is brushing twice per day, or irregular. Our inclusion criteria was informed consent should be signed, age above 18, permanent teeth, crowns and restorations, and brushing frequency. While our exclusion criteria was extracted teeth due to orthodontic treatment, age below 18, primary teeth, temporary crowns, restorations, and third molars. Those were the tests used in our study, and a value of P below 0.05 was considered significant for all the statistical analysis. All the data was analyzed using a total of 476 subjects participated in our study. We had a higher percentage of male, we had a higher percentage of participants aged 18 to 29, and a higher percentage of participants who stated that they don't have any medical problem. When we come to the BMI distribution, we had a higher percentage of normal BMI. And when we come to the DFMT and its component, we had a higher percentage of DFMT score and decayed teeth. When we compare the DMFT with the gender, in female, they had a higher mean in DMFT score and missing teeth and filled teeth, while male had a higher mean in decayed teeth. And when we compare the DMFT with the BMI, overweight and obese had a higher mean in DMFT score and missing teeth, while normal BMI had a higher mean in decayed and filled teeth. In conclusion, the study showed a significant association between the mean of DMFT score and the BMI, while overweight and obese individuals had a significant higher mean and DMFT score compared to the underweight and normal subjects. Thank you so much for listening and stay safe.
Thank you so much. So now we will move to our respected judge, Prof. Amari, Dr. Ansari.
Thank you, Dr. Idail. Interesting study. My question regarding calibration of the examiners. Can you elaborate on that?
Yes. Yeah. To eliminate the discrepancy in the examination, we actually had to work in partners. We also used the WHO guidelines for examination, which is present in the WHO manual for oral survey, the 5th edition. And yeah, that's it. And we also used the...
Have you talked, a random double check of the samples again to be sure that there is reliability between the examiners, even intra-examiner or inter-examiner reliability?
Honestly, we did not do that. But since we worked as partners, for example, I would check the patient and then my colleague would come and check again.
Do you have a justification? It's okay. You have a justification. What's the explanation why the body mass index is correlated to BMI?
You mean to the obese and the overweight?
Yeah.
I think maybe because of that.
Yeah, carry on.
I think it's because of the intake of the carbohydrates. They have higher intake of carbohydrates with the bad oral hygiene habit.
Have you found a support for this in the
MFT index?
Yeah, have you found a support from literature for this?
I found, but it was for female, not for male.
It's okay. Thank you.
You're welcome.
Yes, Dr. Ansari.
Okay. Can you tell me which statistical test did you use to compare the groups?
For all the groups, we used the Turkey's test.
Okay. All right. Thank you.
And those are the rest. Thank you.
Thank you, doctors. Now we will move to Dr. Asail.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. It's my great pleasure to present our research, natural versus synthetic pulmonary surfactant replacement therapy for preterm infant with respiratory distress syndrome. and with our supervisor, Dr. Mohammed Abdul Bari. Introduction: mammalian lungs essentially contain pulmonary surfactant with lipid protein complex to maintain operative respiratory service, and yet neonates born without enough surfactant are exposed to lungs collapse, and it causes respiratory distress syndrome. The ideal treatment for this condition is surfactant preparation that contain phospholipid and surfactant protein B and C. The picture here shows the lung and the alveolus, which contain two types of pneumocyte. Type 1 pneumocytes responsible for the gas exchange, and type 2 pneumocyte have two important functions. It works as a stem cells, and the most important function, which is surfactant production that help to prevent lung collapse and RDS. So in case of the absence of pneumocyte type 2, there will be infant with RDS. Our objective to encourage a new generation of synthetic surfactant that has an essential application to be designed to overcome limitation of natural surfactant and to resolve the mode of administration to non-invasive method in Saudi Arabia. And we should know that in Saudi Arabia, it's considered as life-saving emergency drug, and it's very costly. Many infants suffer, they cannot breathe very well. They need this treatment, but it's costly. So our aim is to develop cost-effective, low-cost synthetic surfactant to save life of infants. Methodology: many articles were reviewed on the importance of surfactant replacement therapy, and different resources were used to obtain these studies. Result: we found that first-generation synthetic surfactants that are protein-free have been removed from the market because they fail to reduce mortality associated with RDS. However, second generation considered as surfactant replacement therapy because unlike first generation, it contains phospholipid, SPB or SPC analogs, was shown to be effective in the treatment and prevention of RDS in a neonate. And the schedule shows the product that is available and approved by the US FDA, and there is synthetic product still in the clinical trial. Conclusion: natural surfactants have many limitations, such as cost, immune reaction, infections elicted by animal protein contained in natural surfactant. A new synthetic surfactant may represent a potential alternative to treat preterm infant with RDS in the coming years. Regarding the mode of administration, further studies are still needed to seek different mode of administration that is safer and more efficient for a neonate, including minimal invasive to non-invasive method. And in the end, we actually have reviewed so many articles to collect most important information about cost-effective alternative synthetic surfactant. And based on that, with the help of our supervisor, we plan to work in this product, which is useful for society in the lab in the coming days, inshallah. Thank you for listening, and feel free to scan our reference. Thank you.
Thank you. So now we will move to our respected judges, Dr. Iman and Dr. Fathi.
Assalamu alaikum. Thank you, Dr. Lama, for your clear presentation. I would like to just clarify certain point regarding your study, a systemic review or meta-analysis. What was your? Yes. What was your? Yes.
It is systematic review, doctor.
Yes. What was your methodology that you included in your study, as you already put certain inclusion criteria or exclusion criteria for the articles that already included in your study?
Yes, doctor. Articles related to synthetic surfactant, to articles related to the route of administration of surfactant, and related to the product that is used in the market. This is our inclusion criteria. About exclusion criteria, it's not related to the topic of natural surfactant.
Yes, but this is a huge number of articles from 1966 to 2019. This is a huge batch. So what's the updated guidelines that you follow in your systemic review?
Sorry, doctor, I cannot hear.
What is the updated guidelines that you already follow while you are performing your systemic review?
Yeah, PRISMA guidelines, 2020.
Yes. Regarding a last point, regarding within your results, you already compared between synthetic surfactant that containing protein, B and S, and the other not containing proteins. What about comparing between, which is the aim of your study, comparing between natural and synthetic surfactant. You didn't mention this point in your results.
Yes, doctor, but we said some of the limitations that regard the synthetic surfactant, like cost and immune reactions. And there is a lot of procedure to make the natural surfactant. There is a lot of procedure to take the surfactant from the lung of the animal, and it needs more time.
Yes, but according to your study, is it clear that the use of synthetic surfactant, reviewing is the articles, it's the same as using natural surfactant?
Yes, actually, it shows that it's as effective as the natural surfactant, or even maybe it's better.
Thank you.
Thank you so much.
Dr. Lama, you mentioned that you are planning for future research. What exactly are you going to?
Sorry, doctor, it's not clear.
What exactly are you planning to continue on researching about this topic?
Actually, we already collect many information about this, and we are planning to collect more and more. Then we will start doing this in the lab, inshallah.
Okay,
synthetic surfactants. Thank you so much.
Okay, thank you. So now we will be back to Dr. Asail.
Assalamu alaikum.
Alaikum salam.
I apologize for the technical issue that occurred earlier.
Yes, you can start.
Greetings, everyone. My name is Asail Al-Juma. I'm a dental intern at Riyadh University. Our research title is The Need for a Smartphone Application to Facilitate Communication Between Deaf, Mute, and Hearing Impaired Patients and Dentists, supervised by Dr. Omar Al-Ghadi, co-supervised by Dr. Bara Abdurrahman. Speech and hearing impaired individuals face serious problems when it comes to communication with healthcare providers. According to the General Authority of Statistics in Saudi Arabia, the number of Saudi citizens that uses sign language are more than 27,748 individuals. Despite the existence of sign language that compensates the verbal language, the communication between the hearing impaired people and the normal people is still difficult. The aim of our study is to assess the need of a tool in the form of a smartphone application that will facilitate an efficient communication and will serve to eliminate misunderstandings between the deaf, mute, and hearing impaired patients and the dental practitioner. The rationale for our study is to determine the difficulty of communication between deaf, mute, and hearing impaired individuals and their healthcare providers. The research questions how difficult it is for deaf, mute, and hearing impaired individuals to communicate with their healthcare provider, and is there a need for an application to facilitate the communication between deaf, mute, and hearing impaired individuals with their healthcare provider. Methodological approach and study design. This is a cross-sectional study. We distributed a self-reported questionnaire among individuals with hearing disability. We measured demographic data, their experience at the dental office, their interest and ability to use modern means of communication, and their willingness to use smartphone, tablets, or computers to communicate with their dentist. 58.5% of individuals with hearing impairment have visited dental offices. 51% of individuals reported they couldn't understand their dentist during their visits. 45.3% stated that their complaints were understood, and 30.2% of information were clear to them. And only 24.5% of individuals were given all necessary information. 73.58% of all individuals are willing to use mobile application to facilitate communication if recommended by their dentist. To conclude, many individuals with hearing disability are facing difficulties in communication in the dental office. The majority of them are willing to use mobile application to help them communicate better in the dental office. The clinical significance of our study is to allow hearing impaired individuals to communicate more efficiently with their dentist via a smartphone application that is specially designed for them. Thank you for listening, and our references are in the QR code.
Okay, thank you, Doctor. So we will move now to our respected judge, Prof. Humari, Dr. Ansari.
Thank you, Dr. Asail, for this
You're most welcome.
innovative approach. My question is that have you, how you communicate with your sample?
Yes, we reached to our sample by communicating with the Saudi Society of Sign Language Interpreters.
Okay, good. And is any support for this study in the literature or similar studies?
No, this in Saudi Arabia, you mean, or generally?
Generally, even in the kingdom and outside. Yeah.
Well, in the kingdom, this is considered to be the first paper that evaluates the use of smartphone among patients with hearing and speech disability to facilitate communication with the dentist. And worldwide, we haven't found similar publications. However, we found several studies that only evaluated the difficulties that the deaf and mute are facing.
Yeah, what's the limitation of the study from your perspective?
The limitation is our access to this minority group, as it needs, we need an interpreter or intervener to help us to reach to them.
Thank you very much.
You're most welcome.
Okay, yeah, I just have one question. Did you check the validity of your questionnaire?
Yes,
and how?
yes.
How
The validity, yes. The questions that were mentioned in the questionnaire were taken from previously published papers.
Okay.
Yeah.
All right.
For the validity. You're most welcome.
Okay,
thank you.
Thank you.
Oh, thank you, Doctor. So now we will move to the last but not least presentation for our young researcher by Dr. Zainab.
Hello, hello everyone, and thank you for giving me this opportunity today. I am Zainab Al-Hajouj, and I'm here today to talk about antibacterial activity of Simobabgon citrus oil and Mira extract against some selected bacteria isolated from Riyadh, Saudi Arabia, supervised by Dr. Muhammad Salah. Starting with why we have chosen this topic. Actually, a couple of years ago, there were many research published on antimicrobial resistance and how the overuse and misuse of antibiotic lead to growing the number of bacteria in humans and resistance to the life-saving antimicrobial therapy. And one of their solution is to overcome this problem is to go more natural and use herbal medicines. So connect this to our goal, which is determine whether the use of this lemongrass oil, which is the other name for Simobabgon citrus oil, and Mira extract as antibacterial medicine alternative to used chemical product, and measure their effectiveness against gram-positive bacteria and gram-positive negative bacteria. This is a briefly introduction about what is Mira and what is Simobabgon citrus. Actually, they are both oldest cultivated plant for medicine purposes in different countries around the world. Their famous use in case of malaria is as antibacterial, anti-inflammatory, and antifungals, while in lemongrass oil is as antioxidant, bactericidal, fungicidal, and it have a sedative property also. Move to the other methodology, which is we have selected 7 bacteria and go it through a GAR diffusion assay, and the bacteria who said it's positively or sensitivity for this method, we move it to the other method, which is the minimum inhibitory concentration assay. As this is the result, as overall, it's clear that from these 2 charts at the beginning, that both of lemongrass oil and Mira extract had a significant effect of sensitivity among this listed bacteria, and only a few have resistance as a display. Furthermore, it's clear that the bacteria had effect for lemongrass oil more than the Mira extract. In MIC method, this is the graph. In MIC method, it's the low concentration of lemongrass illustrate its potent for prevent the growth of bacteria in Candida albicans. This is very low concentration and still have the good effective. In conclusion, as a significant effect of these 2 remedy, we could use it as antibacterial and antifungal medicines, and it is play a good alternative to the chemical product, unless the doctor or the situation doesn't see the need for the urgent use for the chemical product. That's it. This recommendation.
Thank you,
for
Doctor.
listening.
Thank you. Well, now we'll move to Dr. Wakil and Dr. Fathi for their questions.
Thank you, Dr. Zainab, for your valuable presentation. That's already, you all did it inside our labs in REU. But I would like from your reading about this, about your study, do you suggest to use these herbal extracts like Mera to be 100% safe to all cases, all patients to be prescribed?
Actually, doctor, this is as for, we haven't said this for, is it safe for, but it is no in other study. It is safe because they have a low side effect.
Yes, yes, this is sure. Yani, you know that already it can be taken, but with precautions.
Yes, it has precaution, yes, but it is more safer than the chemical product.
Yes, is it safe to be given to a pregnant female?
Actually, we didn't see this as a recommendation, but I believe pregnant women is need its precaution for all uses. So we need furthermore study and investigation for this, I think.
Yes, yes. I would like you to, inshallah, for further to publish your article, inshallah, to include this, but to include this point, it can be used, but with precautions, especially with pregnant female, patient with diabetes, and patient with heart problems.
Right.
It should be used, but with caution. Thank you.
Thank you so much.
Dr. Zainab, what concentration did you use in agar diffusion?
Actually, we've used 1,000 microgram for each gram.
What was the solvent that you dissolved the plant oil or agar or gum?
We only use water.
How did you dissolve the oil in water?
We use it as a mixture, doctor, so it's not dissolved 100%.
So if it is not miscible, what is the main purpose of using water with oil?
Doctor, do you ask me about the agar diffusion method?
Yes.
Okay, the agar diffusion method only if it's for a lemongrass oil, we only use the oil and the technique without any solvent.
So the oil, do you mean 100% oil?
Yes, 100% oil.
Okay, so did you authenticate or identify the plant material? How did you make sure that the oil you already bought from the markets is for the Symbopogon citratus? Or how did you make sure that this plant material myrrh is actually myrrh? Because in plants, in herbals, it's commonplace that these are easily adulterated. So did you identify it?
The product that we have bought by the market, they wrote as their content that is 100% pure as oil, lemongrass oil.
Okay, thank you, doctors. So now we are finished with this. We will move to the next activity. So we will have Dr. Osama Al-Mgharin, the counselor of IDR Saudi Arabia Division and the chairman of the Preventive Dentistry Department in Riyadh Al-Alm University. He will give us a speech about the IDR, a path of research, collaboration, and more. So welcome, Dr. Osama.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله الأمين نبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Dear respected professors, dear doctors, researchers, and attendees, hoping that all of you are staying safe and in the best health. It is an honor to be in front of you today on behalf of IDR Saudi Arabian Division. It's my pleasure to be a part of this activity. I would like to thank all presenters today for their valuable studies and wishing all the best for them in this competition. Actually, they are all winners by reaching this stage and by this knowledge and this performance. I am Osama Al-Mugairin. I am the Counselor of IDR Saudi Arabian Division, Chairman of Preventive Dentistry Department, College of Dentistry, Riyadh University. I will be displaying today our path as a Saudi Arabian Division of IDR in many research aspects. Before I start, please allow me to give a small brief related to the International Association for Dental Research and the story of our Saudi Arabian division. The IDR is a non-profit organization with nearly 11,000 members around the world. The mission is to advance research and increase knowledge for the improvement of oral health worldwide and to support and represent the oral health research community to facilitate and communicate the application of research findings. The IDR Global Headquarters is located within Alexandria, Virginia, USA. And the regional structure is 5 regions, 28 divisions, and 17 sections. This structuring is depending on the number of memberships of every region. For us in Saudi Arabia, we are a division. In 1920, the IDR was founded by James Williams, with the first general meeting taking place in December 10. Today, the president of IDR is Professor Pamela Dempeston, and the CEO, Chief Executive Officer is Dr. Christopher Fox, that I would like honorably to, on behalf of Saudi Arabian Division, to thank him and extend our thanks and gratitude for His Excellency for sharing his time with us today and joining us for the second time. Dr. Fox also was joining us last month within our live poster competition. We were very happy by even his letter that we reached, that sent to us by saying that the Saudi Arabian Division was one of the vibrant divisions. So thank you so much, sir, for giving your time, and thank you so much for attending with us today. In 2020, the IDR celebrates the 100-year centennial. The story of IDR Saudi Arabia, it was founded in 1993 by our mentor and idol, Professor Abdullah K. Bishammari. It was transferred from a section to a division in 2014, as it was the time of the former president, Dr. Isam al-Haydari, at that time. The vision of the Saudi Arabian division of IDR is to be synonymous with scientific research dentistry and become one of the most active divisions in the region. As you see, in 2018, the IDR Saudi Arabian division had a certificate of one of the 3 highest growth recognitions divisions within the world. It was on the time of our former president also, Dr. Sultan al-Rimal, in 2018. Our mission is really to research advancement, knowledge enhancement, seeking for improvement of oral health in Saudi Arabia. It's also to achieve the Kingdoms of Saudi Arabia goal as stated in Vision 2030, to have strategic partnership development with dental institutes to expand the research field. That is the main concept and aim for my presentation today about our collaboration in many research aspects. Many researchers are asking, why do I have to be an IDR member? IDR member has a lot of benefits. One of the most important benefits that you will have an access for many journals. One of them is the Journal of Dental Research, that it's ranked number 2 with an impact factor of 5.1. It is also ranked number 2 within 90 articles influence. Another also journal that you will have an access is the Journal of Clinical and Translational Research, and many other journals that is within the IDR institution. The second important thing that there is 32 IDR scientific research groups and networks that any IDR member can access easily. This is a small video that will display, if you are an IDR member, how can you reach these groups. You will just enter the website, go to group and networks. After that, you'll display a lot of scientific group that you can read about, join them, and be within this projects of valuable research. There is also a lot of reward yearly by the IDR. There is 40 awards and fellowships in various categories, including Students Award. Every year there is hatting competition that every division and section is performed for junior and senior clinical basic sciences. January this year, 2020, our board members was nominated as a Saudi Arabian division's members. Our president is Dr. Adima Shamari, my colleagues, Vice President Dr. Adhana Safan, Dr. Adal Ataybi, Dr. Turki Bakhsh, and myself as the counselor of this board, Osama Magairan, and we are really having the continuity of all previous board members. To be honest, all of our collaborations, all of our achievement that happened, it will not be happened if we were not continuing the work that has been started since the founded of our respected mentor, Prof. Abdullah Shammari, passing until we have become a division through the former boards, Dr. Isam Al-Hadhi and his colleagues, after that Dr. Faisal Al-Shail and his colleagues, and then Dr. Sultan Birmal and his colleagues, until we had our board this year. In this 6 months, we achieved a lot of achievements, a lot of collaborations with a lot of institutes around the kingdom, as a continuous work of our colleagues before. As you see in this slide, around the kingdom, we have collaborations with many and a great number of universities around the world. We are very passing our gratitude to them about our achievement. It will not happen without their help, their support. I will start, if you allow me, by the representative of the Ministry of Health, Dr. Mohammed Al-Dosari, that represents the Research Center of Ministry of Health of Kingdom Saudi Arabia. In the central region, we have King Saud University, represented by Dr. Manna' Al-Dosari. Riyadh Al-Almī University is represented by Dr. Umar Al-Qadhi. King Saud bin Abdulaziz University for Health Sciences is represented by Dr. Nadia Al-Angari. Prince Noura bin Abdurrahman University is represented by Dr. Rashad Al-Harthi. Prince Sattam bin Abdulaziz University and Al-Kharj within the central region is represented by Dr. Nasser Al-Qahtani. Al-Qasim University is represented by Dr. Faraj Al-Ataybi. Going to the western region, we have King Abdulaziz University that is represented by Dr. Turki Bakhsh. Al-Qura University that is represented by Dr. Muhammad Al-Harthi. Taiba University that is presented by Dr. Hani Ghabbani. Taif University that is presented by Dr. Muhammad Fahmi. While we go to the eastern region, the Imam Abdurrahman bin Faisal University, represented by Dr. Amari Ibrahim. Going to the southern region, King Khalid University in Abha is represented by Professor Ibrahim Al-Shahrani. Jazan University represented by Dr. Muhammad Mashayikhi. And last but not least, Najran University represented by Dr. Bandar Al-Yami. We are aiming also to reach the complete number of all governmental universities, private sector universities, and even hospitals, private centers, that anyone have an interest or a research center that will help and support our collaborations. We started in February 2020 after our nomination. We joined a lot of events at scientific collaboration, starting by EDIC in Dubai, then the Saudi Orthodontic Society annual conference that was also in the end of February. After that, Prince Sattam University as a part of the forum poster competition, and then King Saud bin Abdulaziz University National Guard. We also was a partner with them in their dental interns activity. Also, we was honored in King Saud University by the dental intern office program. We joined them also as a collaboration. Princess Noura University also, we joined them within the dental intern research projects day. In the past 2 months, within what we had as webinars within the online participation and conferences, we started by collaborating with the mother society, the Saudi Dental Society, within their online SDS International Conference. All of these posters display our webinars that was given by distinguished speakers within all around the kingdom and around the world that we had in the past 2 months, gratefully. This is a very important part also about our collaboration as a Saudi Arabian division, is our collaboration with the mother society of dental in Saudi Arabia, that is Saudi Dental Society. We had last May the electronic e-poster competition award with the participation of 150 participants that came from 22 universities around the kingdom. it is a chance really to pass my grateful thanks to Professor Khalil Al-Isa, the president of the Saudi Dental Society, for all his believing in us, all his support, all what he gave us, and it was an honor collaborating with the Saudi Dental Society. We really had another part of collaboration as we started launching databases, forums, platforms that will help to connect all the researchers around the kingdom with the specialized societies. We started by the Saudi Orthodontic Society with the president, Dr. Mohammed Al-Harbi, that I would like to thank him also, that we launched a research data platform that anyone that is a member of Saudi Arabian division of IDR and Saudi Orthodontic Society can access this platform and can connect with a lot of research groups around the kingdom. Also, the same thing, we were honored to do a researcher database in restorative dentistry with the Saudi Society of Restorative Dentistry. Grateful thanks to their president, our mentor, Professor Abdullah Shammari, as we are starting also to do the database. Continuing also our collaboration happily with the researcher database with the Saudi Prosthodontic Society, with their president, Dr. Mansour Asiri, with grateful thanks for their collaboration with us. Also, we are continuing our collaboration with the Saudi Society of Periodontology. Grateful thanks also for the president, Dr. Abdullah Al-Amri, for all the collaboration. We started our scientific activity last month with one of their webinars. Okay, and we are continuing also our collaborations. Continuing with the specialized societies, also the Saudi Dental Education Society, as we are having our initial agreement, okay, with their president, Dr. Munir Al-Shabib. We want to thank them also. Our aim also, as we said in the universities, to continue collaborating with the society, with the specialized societies. So we are aiming also to complete with the Saudi Pedodontic Society, the Saudi Endodontic Society, and the Saudi Oral Maxillofacial Society. This is our aim, to reach all of this collaboration that will give us our strength and will help and will serve the research in Saudi Arabia. Last but not least, our current event that is going now within Riyadh Al-Ilm University, that's the third summer school. We are having 150 participants from 19 universities in Saudi Arabia, 9 private clinics. We also have participating from outside Saudi Arabia that help within having this school as an online school, okay, to participate with us within the summer school. Within the 6 months, alhamdulillah, this is by all, as I said in the beginning, the continuous work of our former board members of the Saudi Arabian divisions. With the help and encourage of all of my colleagues in the Saudi member, we gained all of these achievements within our first 6 months, aiming also to complete our mission and vision. This is our the IDR website. Please open your cams and zoom in to have the barcode. The memberships for a student is $54 and $175 for regular members. This is our accounts on the social media, Facebook, Twitter, YouTube. Also scan the barcode, zoom in to have to visit us. At the end of this presentation, I will really pass my gratitude and thanks for the organization committee of the 11th Research Day. We are honored to be collaboration for 11 years as a Saudi Arabian IDR division within the Riyadh Al-Ilm University within the annual Research Day. Wishing all the success for everyone. This is a poster. I would like to invite you all to join us tonight for our webinar tonight that will be presented by Dr. Kantraki. He is presenting from Boston, USA, with a very interesting topic: bone biology and orthodontic treatment as publishing a dental research. Thank you so much. Hoping everyone to stay safe and see you soon. This is Dr. Osama Al-Mughairin, Consular of IDR. On behalf of IDR Saudi Arabian Division, I will thank you for listening. I'm also proud to be a member of Riyadh Al-Ilm University College of Dentistry. Thank you so much.
Thank you, Dr. Osama. We are very proud of your teams for this activity of IDR Saudi Division, and we hope always our division stay in the top. So now we will continue our program. We will move now to Prof. Ashraf Kamel, the Director of Research Center in Riyadh Al University. He will start announcement the result.
بسم الله الرحمن الرحيم والصلاة والسلام على المبعوث رحمة للعالمين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. Can you see my screen, Dr. Sultan?
Yes, Doctor.
It gives me the greatest pleasure and honor to welcome you all again to Riyadh Ilm University 11th Research Day 2020. I am personally delighted to announce the final results of the competition of this year's 2020 Research Day. But first, allow me to give a well-deserved big vote of thanks. At the beginning, I have to admit that this event, the 11th Research Day, will not have been possible in the current COVID-19 pandemic without the sincere efforts and dedication of a big team in the Research Center of Riyadh Ilm University, working in harmony, day and night, work days as well as weekends. In this regard, I must thank the following. First and foremost, we are all grateful to Allah, the most gracious and the most merciful, for keeping our country and families safe and for giving us the power and ability to plan and conduct such a big scientific activity. Falhamdulillahi Rabbil Alameen. Most importantly, I would like to express my deep gratitude to the respected chairman of the Board of Trustees of Riyadh Ilm University, our mentor, His Excellency Professor Abdullah Shamari, for his continuous encouragement and valuable guidance throughout the years, and who is the legitimate father of the Research Day of our university. The Research Center is grateful to the respected director, Dr. Saleh Al-Shamrani, for his continuous wise instructions and for facilitating all the difficult situations to make this event successful. We are deeply indebted to the organizing committee headed by the respected Vice Rector, Dr. Mansour Aseri, to whom the idea of conducting this virtual 11th Research Day online in spite of the COVID-19 pandemic situation, as well as the respected members of the organizing committee, Dr. Dima Al-Shamari, Dr. Sultan Al-Rimal, Dr. Omar Al-Qadi, and Dr. Ahmed Al-Sir. This online event will not have been possible without the genius support of our IT department, headed by Mr. Alwin D'Souza and his team. I am truly thankful to the respected members of the board of the Research Center, Dr. Hana Al-Khabbas, Dr. Omar Al-Qadi, Dr. Muhammad Abdul Basir, Dr. Kristal Souman, and Dr. Ahmed Al-Sirri, whose valuable efforts throughout the academic year made the Research Center an efficient and productive in supporting the mission of Riyadh Ilm University. I'm grateful to the sincere efforts of the media committee headed by Dr. Sultan Al-Rimal and his team of our REU talented students who spread the word of this event all across the social media and brought together all the webinar attendees today. We are in the Research Center deeply indebted to our keynote speakers, respected Mr. Abdulaziz Abdelbaqi and respected Dr. Christopher Fox, who truly enriched this Riyadh Ilm University 11th Research Day today. And the Research Center would like to express its sincere gratefulness to the esteemed panel of judges who shared in the evaluation of the 82 plus the 18 today research projects and who are senior faculty in Riyadh Ilm University. Without their meticulous and constructive evaluation, this event would not have been successful. Before I announce the results of REU 11th Research Day competition, I want to stress on an important point, that each and everyone who submitted his or her research and presented it in this event today is in itself a prize. As an undergraduate student or an intern or a postgraduate master student in REU, being able to conduct and complete and then stand up here in this event to present your efforts and ideas is such a great achievement. But in every contest or a competition, there are ranking and winners. But today, we are all winners. Each and every one of the 400 plus researchers who submitted 82 research projects, all of you are winners today. And we are all in REU proud of you and encouraging you not to stop, but to continue actively in this long road of scientific research. So I thank every researcher who participated in this 11th research day from the bottom of my heart. And now I'm going to announce the results. First place, postgraduate research, title, Fracture Resistance of Different Veneering Techniques of lithium disilicate crowns. Second place, postgraduate research, the effect of in vitro aging on the color stability of cubic and tetragonal zirconia materials by Dr. Maha Meziet, Supervisor Dr. Fawaz Al-Qahtani. For the community dental public health, first place, knowledge, attitudes, and practices toward COVID-19 in a Saudi Arabian population, a cross-sectional study by Dr. Reem Hirbish, Sarah Al-Mufadda, Noof Al-Khraj, and Banr Mishari, supervised by Dr. Abdurrahman Al-Saffan. Second place, community and dental public health, the need for a smartphone application to facilitate communication between deaf-mute and hearing-impaired patient and dentist by Dr. Asail Al-Jum'a, Lin Al-Mani', Haifa Al-Salmi, Shayma Al-Hawas, Supervisor Dr. Omar Al-Qadi and Dr. Bara Abdurrahman. For restorative and endodontics, first place, evaluation of light curing intensity output and students' knowledge among dental schools in Riyadh City by Dr. Mona Al-Inzi, Sarah Al-Amri, Mura Al-Fassam, Sarah Al-Muammar, Supervisor Dr. Sultan Al-Rimal. Second place, restorative and endodontics, comparison of the fracture resistance of 4 different recent composite restorations after thermocycling, an in vitro study by Safa Al-Da'ij, Reem Al-Eid, Noura Al-Hafi, Samar Abu Talib, Supervisor Dr. Ihsan Al-Kushtini, Dr. Isra Al-Daiji. For the oral maxillofacial surgery, orthodontics, and pedodontics, first place, the effectiveness of automated soft tissue vibration in reducing pain and accelerating action of intraoral local anesthesia injections in adult dental patients, a randomized crossover clinical trial by Abdurrahman Al-Sayah, Abdul Aziz Mana', Faisal Al-Rassan, and Abdurrahman Al-Marshad, Supervisor Dr. Ra'id Salam. Second place, in Omphis, orthodontics and pedodontics, functional appliances, effectiveness and stability of treating class 2 skeletal malocclusion, a systematic review by Dr. Hassan Al-Alawi, Dr. Thamir Al-Gannas, Dr. Hassan Al-Hassan, Dr. Mut'ab Al-Shambari, and Dr. Faris Al-Qahtani, Supervisor Dr. Nancy Ajwa. For orthodontics and periodontics, first place, the effect of periodontal treatment on hemoglobin A1C levels in diabetic patients, a systematic review by Dr. Basil Al-Ghamdi, Dr. Hassan Alawi, Dr. Mansour Johari, Dr. Muhammad Hakmi, and Dr. Haider Al-Khalifa, Supervisor Dr. Rakan Shahid. And the second place in orthodontics and periodontics, locator attachments, patient satisfaction, success rate, peri-implant health, a systematic review by Dr. Ruwaida Rashid, Rand Bakhsh, أصيل المزيد, لنا الخضير, جدايل الوهيبي, and أمجد الفايفي, Supervisor Dr. Zaki Faqiha. In pharmacy, first place, antibacterial activity of Simbopogon citratus oil and Mera extract against some selected bacteria isolated from Riyadh, Saudi Arabia by Dr. Zainab El-Hajouj, Wajdan Al-Muteri, Nawal Al-Inzi, Riham Mahdi, Mariam Al-Khidir, Supervisor Dr. Muhammad Salah Ali, and Dr. Samar Al-Toum. Second place in pharmacy, natural versus synthetic pulmonary surfactant replacement therapy for preterm infant with respiratory distress syndrome by دكتورة لاما الغنام, دكتورة هاتون الريس, دكتورة حنان الأجيان, and دكتورة أنهار البش. Supervisor Dr. Muhammad Abdul Bari. This concludes the results of our competition this year. And as I said, we are all winners. Of course, I congratulate those high rankings in every specialty, and I congratulate all participants in this scientific event, and thank you very much.
Thank you, Prof. Ashraf. So now we will move to our respected Vice Rector, Dr. Mansour Asiri.
Assalamu alaikum. Good evening again. On behalf of the organizing committee, I would like to make few comments and thanks. The first comment and thanks go to Prof. Masadomi and Dr. Sharat Bani, who joined us for the last 10 research day, and we tell them we miss you all. They are with us. Prof. Masadomi is joining all this afternoon session from Lagos, Nigeria, and Dr. Bani from London, Ontario, Canada. So I'd like to thank them for all the effort that they did for us before, and we're looking for more cooperation with them. So thank you for attending with us. The competition, as Prof. Ashraf mentioned, it was tough, more than 80 abstract, and the 18 who presented today from my side, you are all winner. Congratulate to the winner, but this is the competition. There is a prizes, but all of you, you are a winner today. The virtual day, it would not have been possible without the teamwork with the organizing committee, with the audio visuals in our university. So I'd like to thank them all. I'd like to thank you all, those who attend this activity, and looking forward to see you soon in the future activity of our university. Thank you. في أمان الله.
Thank you all, and on behalf of the organization committee, I would like to thank our student. All the event of Riyadh Ilm University, our students should be the first line or the first organization committee. So I would like to thank Dr. Abdullah Bahmed, Dr. Abdullah Al-Atabi, Dr. Abdurrahman Al-Ammari, Dr. Muhammad Al-Shuraida, Dr. Muslat bin Rabi'an for their hard work. And we'll see you, inshallah, next year by 12th Riyadh Ilm Research Day. Thank you.